So like Matt said, my name is Joel Porter. I work at a Station 2. I know most of you in here, but not everyone. They asked me to come in today and do a presentation on manual Defib coming from a lower level provider, the BLS partner. It's not difficult, and it'll make it seem like it's too easy, but we're just going to review some different aspects of the anatomy, what defibrillation means, what rhythms we're going to shock, what's going on with the heart during those rhythms, and then we're going to discuss the dosaging and our timeline of events. So this is our basic anatomy of the heart. When it comes to conduction, we're going to be concentrating on the SA node, going into the AV node, through the bundle of His, bundle branches, and down through the Purkinje fibers. Your SA node is your primary fire, has an intrinsic rate of 60 to 100. And then that sends a shock down to the AV node. There's a pause, sends down both bundle branches, and then around the heart to bring the conduction back around. So defibrillation is a therapeutic dose of electric energy. Your heart is in a non-life-sustaining arrhythmia or dysrhythmia. So it's going to depolarize the critical mass of the heart and attempt to shut the heart down to allow the SA node to regain control over that heart. It's not a jump start, but more of a reset. When I think of a jump start, I think of a dead car battery, which makes me think asystole. We don't shock asystole, so it's more of a reset. It's when you're playing your video game and it freezes up or starts glitching. We're going to hit that reset, shut it all down, and hopefully it restarts on its own. Automatic defib, it's step-by-step, it's time-consuming. It's just for the lay person or the minimally trained person. It's for that person that took a CPR AED class 1 year and 11 months ago, that they're kind of familiar with it, but it's going to walk them through every step. A lot of times we're 2 or 3 steps ahead of the machine, so then we're just waiting for it to have the prompts. It takes up to 30 seconds to analyze. My partner and I looked at a YouTube video, and it was over 30 seconds for analysis, recognition, charge, and shock on a Philips manual AED. And for it to not shock, it was 17 seconds. That was telling you to stay off the chest, so that obviously breaks our HA standard of 10 seconds or less. Manual defib, we're actually going to charge this shock up prior to analysis. So before we're even looking at the rhythm, before we're even having someone stop compressions, this shock is ready to be delivered. This saves time where you can deliver your shock in under, it's going to be about 3 to 4 seconds that you're only off the chest. We're going to immediately deliver the shock if we determine it's a shockable rhythm. If there's not a shockable rhythm present, we're going to dump the charge, which we'll show you how to do on our monitors. So the benefits, we're going to significantly decrease that peri-shock or that pre-shock pause, which is the pause between rhythm analysis and actually shocking. Minimizing time without compressions, we're going to keep that heart primed. This is why we don't shock asystole. It wouldn't hurt the heart at all, but it eliminates time off the chest, which is what we're most concerned with. When you build up that interthoracic pressure, you are allowing the heart to be primed, so it's going to get the most out of that shock. Just in this article that was released by Circulation, the impact of pre-shock pause on survival suggests that refinement of automatic defib software and paramedic education to minimize pre-shock pause delays may have significant impact on survival. It's proven that time off the chest and the time that you delay is hurting your patient. So they want it to be at the paramedic education. We're dropping it down to the BLS, which, like Matt said, is in the BLS scope of practice with proper training and medical director approval, which we have obtained from Dr. Jesslin. So shockable rhythms, there should be about 4 rhythms present during cardiac arrest. You're going to have pulseless VTAC, Vfib, asystole, and PEA. There's different versions of PEA, but just PEA in general. Only 2 of these are shockable, and that's going to be your Vfib and VTAC. Asystole, there's no cardiac electrical activity. Success rates are much lower than that of patients with a rhythm amenable to defibrillation. So that means a rhythm that's able to be defibrillated. So it's out of hospital, it's only less than 2% survival rate. PEA, it's previously known as electromechanical dissociation. Essentially, your heart is getting the signal, the muscle's not listening. So you have the signal sent, but the muscle's not contracting the way it should be. So it's going to look pretty normal, and it's going to be organized with an unresponsive patient and no pulse present. VTAC. So this signal is sent from the ventricles. It's usually isolated to one area of the ventricles, so it's going to look organized. There's monomorphic and polymorphic. These top 2 are monomorphic, so it's really organized. Polymorphic, also known as like torsades. It's actually going to flip. So what's happening is it's sending the signal from one part of the ventricles or multiple parts in like polymorphic, but in polymorphic, the ventricles are pumping, so the heart doesn't allow it to expand, so it can't fill up from the atriums. Your ejection fraction is so low that it's not going to throw out a pulse. You're running your car without oil. It's life-threatening. It can lead to Vfib or asystole, but it must be pulseless to defibrillate. If they have a pulse and they're in VTAC, Tyler discussed that. You're going to let the ALS partner take care of that. Vfib. So this is multiple signals being fired from the ventricles. So essentially your heart's quivering, and it has the same impact to where you can't allow for filling from the atriums with each expansion. So when it contracts, there's no blood to eject. You're not going to have a pulse. They're not going to stay in this for very long, but it's the most commonly identified rhythm in cardiac arrest patients, and it's one that we can work with really well. There's coarse Vfib and fine Vfib. Coarse Vfib is just broader. Fine Vfib is kind of a more narrow. Your coarse Vfib is what we're going to look to shock because it has a lot of electrical activity going on, and we can shock that and deliver the shock, and it's hopefully going to have better outcomes. In Washington, Seattle, King County, they have an over 50% success rate with their defibrillation on getting ROSC. That's with the witness arrest, and they're going into Vfib.
What's ROSC?
Return of spontaneous circulation. When you get the pulse back. So who in here is not a paramedic or CC? Okay, so we're just going to kind of go around just between you guys. Just raise your hand if you can identify the rhythm and let me know if it's shockable or not shockable. Who can identify that rhythm and tell me if it's shockable or not? Okay, so does it look organized? It doesn't look very organized. It's kind of like a scramble. Through VTAC and Vfib, the easiest way that I found to remember it is something that I was taught in basic. VTAC is the old way you used to brush your teeth when you were a kid. It's just that straight up and down motion. And Vfib is the first time you ever tried one of those automatic toothbrushes and you put it in, it kind of skips all over the place. I don't know why, but that stuck with me. So if that helps you remember what kind of rhythm it is. So if you think tack toothbrush, I don't know. So this one's disorganized. Looks like there's probably multiple firing points. This is going to be Vfib. Are we going to be able to shock Vfib? Yeah, Vfib's a shockable rhythm. And how does this one look? Does it look organized? This looks like, you're brushing your teeth just straight up and down like you did when you were getting your first teeth. So this is going to be VTAC, and it is shockable. What about this one? If they have no pulse and they're unresponsive, are we going to shock that? No? Okay. That's going to be your PEA, or your pulseless electrical activity.
And just to clarify, that last one, the VTAC was pulseless as well.
Yes.
All of these are pulseless.
So you see this on the monitor, a person's unresponsive with no pulse. You have your partner hold off on compressions, and this is what you see on the monitor. What is that looking like? Is that organized? No, it's multiple firing points. So this is going to be back to that Vfib. This is the first time you put that automatic toothbrush in your mouth. It skips around. And what one's that one? Okay, are we going to shock asystole? No. Perfect. How about that one? Hartley. Yeah? What rhythm is that looking like? Okay, perfect. Yep, and we're going to shock that every time. Pulseless. So here's our cardiac arrest protocol. It still says in the protocol that it's going to be paramedic with manual defib, but that's going to go down obviously to the BLS levels. It gives our timeline within here. So this is something, if you're sitting around your station, just keep reviewing that, especially because it's a new thing. We're going to be covering this over the next few months, so it won't be, like Matt said, you're not going to walk out today and start shocking people. But if you review that, you can kind of review your timeline. It does not have the dosaging, so we're going with AHA standards. And here's our PEDS. The difference is our second priority is defibrillate on an adult. on a ped, it's going to be our first priority if you actually witness the arrest, which we'll go over in a second here. Here's our algorithm for peds, and it has your dosaging over here, which I transferred that on another slide. So we're going to discuss monophasic versus biphasic. We do have 2 monophasic monitors in our fleet, so you probably don't have it on your truck, or you might not, but if there's any trade around or anything like that, obviously squads get switched for maintenance and stuff like that, you could come across a monophasic. They're labeled appropriately in very bold print. But the difference is monophasic is going to send the shock from the side up, so it's going to hit the ventricles first and send it up towards the SA node, which is why we put our patches here, because our heart sits here and at an angle, right? So we put our pads here and here, so that way it can go in line with the heart. Where our biphasic, it sends the shock up and then wraps it back around. So why that's important to us, what kind of shock it does, your dosaging is going to be different. You're going to turn your monitors all the way up. On a monophasic, you're going to go up to 360 joules. On a biphasic monitor, which is the majority of our monitors in our fleet, it's going to be 200 joules. For peds, this is in that algorithm. Your first shock is going to be 2 joules per kilo. Your second shock is going to be 4 joules per kilo, and any subsequent shock after that is going to be greater than or equal to 4 joules per kilo with a max dose of 10 joules per kilo. And your pediatric dosing is on your Broslow tape as well. So if your partner has that out for ACLS meds, you can reference that for your pediatric dosage. Just remember 1 kilo is 2.2 pounds street math, just divide by 2.
Is that the same with monophasic and biphasic for these doses?
Yeah. Yeah, it's going to be the same because you're actually doing joules per kilo rather than just a straight, just a set amount of joules. So our series of events, if we're a witness arrest, we're going to charge and analyze immediately. That's going to be your greatest outcomes. If it's unwitnessed or the patient has a downtime longer than 4 minutes, you're going to do 2 minutes of high quality CPR. You're going to prime that pump. At 1 minute and 50, you're going to charge to the correct dose. That thing's going to start screaming at you. It's going to have a loud tone. Have your partner pull off on compressions, analyze the rhythm, decide if you're going to either shock or dump the charge, which, like I said, we'll show you on our monitors. And that should only take 3 or 4 seconds that you're staying off the chest, so you're going to keep that interthoracic pressure up.